A very small section is that of the significant issue we find in some patients with pulmonary hypertension. Now, pulmonary hypertension can be an idiopathic disease. There's absolutely no doubt about this, in which case, when it's an essential disorder, well, it's pretty complicated to try and reverse any of the problems that are ongoing. It is a very nasty disease. As you remember well, pulmonary hypertension, by increasing the afterload to a right ventricle, should result in ventricular failure. And when lung diseases cause heart disease down the road, don't forget we call that cor pulmonale. Now, some known causes of pulmonary hypertension are simply left-sided heart failure. Since left-sided heart failure will cause pulmonary congestion, and this alone, by increasing capillary pressure, would result in pulmonary hypertension. That is without talking about all the fibrosing diseases that could affect lung tissue. Think, for instance, just those rare and unusual, except the day of the exam, pneumoconioses. That could be an issue. And don't forget the issues also of untreated left to right type of shunting. That could be quite relevant here also. Whatever the case might be, as we see in pathology, we were really in need of drugs that would be more selective of the pulmonary vasculature than the systemic circulation. So here are 3 drugs in the US that are used for pulmonary hypertension. They each have a little story. You will want to know bosentan on your exam. This is the prototype of an endothelin receptor blocker. Endothelin, if you want ET, is actually a powerful vasoconstrictor. It's considered the most powerful vasoconstrictor known to date, even more potent than angiotensin II. Bosentan blocks ET receptors, and amongst the ET receptors, it is the ETA receptors that are blocked by the drug bosentan. It has the advantage of being given orally, and as such, can be used in outpatients. Bosentan, otherwise, as far as side effect, shows you in your book that it can cause some hypotension and potential reflex tachycardia. You know, this is simply a sign that this specificity for lung circulation is probably a little bit overrated and more of an in vitro issue than in vivo. Now, the old drug that was used for pulmonary hypertension is prostacyclin. Prostacyclin is the endogenous compound. The analog that is used is known as epoprostenol. You see prost in the name. Well, this one would work very well in lung tissue. As a matter of fact, never forget that prostaglandin analogs are used to keep a patent ductus arteriosus in little babies who would need it. So showing you a good dilatory effect in pulmonary circulation. Problem with it, it has to be given through slow IV infusion, therefore through a pump. That requires your patient to become an inpatient. This is costly, this is more invasive, of course, than the drug bosentan. Also, when you use anything that has prost in its name, don't forget the contraindication, CI for contraindication, in pregnancy. The final drug on this slide is the drug sildenafil. Now, unless you knew this, you would probably think that the board is joking with you if they were trying to treat pulmonary hypertension with the drug sildenafil. Sildenafil is, of course, the famous Viagra, which is used in erectile dysfunction. So why would I use this drug in pulmonary hypertension? Well, simply because the phosphodiesterase type 5, which is inhibited by sildenafil, is actually an enzyme that is not only found in the vasculature of the corpora cavernosa of the penis, but are also found, these enzymes, in the big pulmonary arteries. So that increased cyclic GMP through phosphodiesterase inhibition will cause significant pulmonary artery relaxation. It is actually an FDA-approved use of the drug sildenafil to be indicated for pulmonary hypertension. Well, this brings us to the end of this chapter on blood pressure medication and, of course, on drugs that would be commonly added to the ones we'll see next, which will be the ones with congestive heart failure and the ones for angina.